So allergic fungal rhinosinusitis is an inflammatory condition where you get swelling of the sinuses around the side of the nose, and we think it is caused by a reaction to fungal spores that all of us will breathe in from the environment around us. But in certain individuals, for some reason, there's an exaggerated reaction in the tissue that lines the nose and the sinuses that causes polyps to form, which are little grape-like swellings that appear within the nasal cavity, but also in the sinuses themselves. And then what happens is all that swelling occurs, it traps mucus in the sinuses, and you get this kind of thick peanut butter-like mucus that forms, and more of the fungal spores get trapped, and then the whole thing becomes a vicious cycle. It's a sort of an extreme version of, so we see patients with a condition called chronic rhinosinusitis with nasal polyps, this is sort of part of that spectrum, but in this circumstance it's the fungal spores that are causing the mischief. Whether it's truly allergic or not, or whether it's just an over exaggerated immune response is a matter of some debate in the field. Not all patients will have demonstrated allergy to fungal spores. The classical descriptions of the case talk about the problems only being on one side of the face, so only one side of the sinus is being affected. And certainly when you talk to American colleagues, they will talk about a lot of these cases being one-sided. But certainly in a UK setting, I would say that these conditions tend to be bilateral, tend to affect both sides of the nose and sinuses. So as I mentioned, it's fungal spores that all of us are exposed to in the environment around us. So typical spores include Aspergillus and Alternaria, and these can peak at different times of the year, but can tend to be sort of more prevalent, perhaps sometimes at the end of the summer months. There's evidence that suggests that particularly at the end of the thunderstorms, Alternaria spores can be sort of thrown into the air in greater concentration. Again, there's a lot of debate about whether it's sort of more common in the countryside or more common in older houses. Certainly one or two patients will come in and talk about sort of, the mold on their windows, is that an issue? Possibly. I don't think it's a sort of given, but certainly taking steps to kind of eliminate potential sources is important. And I guess for those people that may be exposed to sort of areas of mold, so perhaps someone who's a farm worker, there's sort of moldy hay or grass sort of stored in a barn, that may be potentially an issue. So the symptoms are the same with all forms of chronic sinusitis. So nasal blockage, nasal discharge. As I mentioned, the mucus tends to be very thick in nature, and people talk about this sort of rubbery consistency of the stuff they produce from their nose. A loss of the sense of smell. These patients are usually particularly badly affected with smell, so usually they get nothing at all, what we call anosmia. And they may experience facial pressure just because of the buildup of material in their sinuses. Facial pain, so outright sharp pain, isn't usually a feature of chronic sinusitis and these conditions. Well, as I mentioned, it tends to be more severe, and because of the features I've already described, it can cause the sinuses to expand, and so people may experience sort of splaying. So the nasal bones here may start to widen, so people have a very broad nose. In really bad cases, it can make their eyes start to move out because the sinuses are getting pushed into the eye socket and causing the eyes to come out. Or the eyes may be pushed apart because of the sinuses in between expanding. So those are all kind of things that to indicate that this may be a sort of one of these worst cases where this exists. Also, these patients typically tend to get problems with asthma, so they tend to be more prone to asthma, and the asthma tends to be worse when the symptoms in the nose and sinuses are worse. It can be difficult to diagnose as a separate entity from all the other sort of aspects of chronic rhinosinusitis with nasal polyps. So typically, if you see a patient, you're going to look inside the nose, you're going to see nasal polyps. For me, my index of suspicion will be that the polyps are particularly big, the patient's symptoms are particularly severe, the mucus in there looks particularly thick. A lot of patients that I've seen over time have come to me because they've had lots of operations and wondering why they're still having problems. So that for me is a kind of subtle marker. When we see these patients, I'll get a CT scan of the sinuses, and one of the clues on the CT scan is that they have something called a double density sign. And what that means is that the thick mucus inside the center of the sinuses has a different density on the scan than the swollen tissue. You can see the two different contrasting areas on the scan, and it has to be someone with an expert eye that's used to kind of picking that out, because the average glance at a scan will just show that the sinuses look full. But if you've got this index of suspicion, you'll look at that and go, okay, well, this is someone who's clearly got this additional sign. And then additional tests that you want to organise will be to arrange an allergy test. That can be either a skin prick test or a blood test that's known as a RAST inhalant screen that can look for evidence of fungal allergy. And also taking the samples of that thick mucus and sending it to a lab, asking them to do special testing for fungus, including silver stains that can pick out that there is fungal spores present. And so it's building a picture of evidence. Sometimes, even despite all of that, it will only be on a patient that I've operated on them and they come match clinic afterwards that the picture starts to emerge. And that may be because at the point prior to surgery, that because of the treatment they've had, things are a little bit masked. And it's only after the event that you really start to kind of find the evidence, find this kind of thick mucus, and be able to harvest it and come to the conclusion that they've got this problem. If you suspect the condition, and certainly if you diagnose the condition, the treatment really is surgery, surgery. So, you know, for most other forms of chronic rhinosinusitis, we'll talk to patients about trying medical treatment and then moving on to surgery if medical treatment fails. But in this particular group of patients, really, it's moving straight to surgery because you just need to get clearance of all this material. You need to get access to get the treatment on board. And even when you've done that, they are often going to be difficult to manage. So you have to be aware that even after surgery, the visits need to be regular. The patients need to be counselled on really being super compliant about how they look after their sinuses. So they're doing their treatment twice a day with their rinses, with steroids added. And in some cases, they may need some help with steroid tablets as well. I should mention that if despite use of steroids, both by mouth and by the rinse method, it may be necessary to give patients antifungals. It's important to emphasize here that we don't view this as an infection, so this isn't a fungal infection, but it's killing the fungal spores with antifungals can help break the reaction that the fungal spores cause in the tissue. And actually, some patients, giving them a period of antifungals can help them sort of break the cycle and get back on top of the problem. In a few cases, and I have a couple of patients that I can think of, they opt to remain on antifungals in the longer term because they just find that they don't get any particular issues with taking the tablets, and that they're quite happy with the relief they get, and they find that every time they come off the antifungals, the problem just deteriorates, so they want to stay on them. But that's a personal judgment for the patient to make with the treating doctor. So in the future, it is likely that a new form of medication may become available to treat this condition, and these are known as biologics. So biologics are what we term as monoclonal antibodies, and basically what those do is they kind of try and block parts of the inflammatory pathway. So they block where molecules come together and create the cascade that causes swelling and causes reaction in the tissue. We're seeing those now being used for asthma. They've yet to, in the UK setting, receive a license to be used in sinus disease. We've done a lot of work in the background, particularly in the British Rhinological Society, to try and provide guidelines and look at the evidence for where these fit in. But as yet, the sort of body which approves use of medications in the UK, the National Institute for Clinical Excellence, has yet to approve them in a sinus setting. So at the moment, these drugs are only really available through respiratory physicians where they deem that the asthma is bad enough to warrant their treatment, and that is a route in. The main problem with these drugs is at the moment they cost £10,000 a year to use, so they're not cheap. Now those costs will come down with time, and of course you can imagine in a private setting no one's really going to want to pay those costs. But as the costs come down, I anticipate that they may become more available, both in the private setting and of course as well in an NHS setting. So I think the key reason I got into my field that I'm in presently was when I was a trainee, I was given a research project to develop an apparatus for testing the sense of smell. And as I wrote up my research, it quickly became evident that here was an area where there was a lack of research, a lack of evidence to support treatment, and largely a lack of empathy for patients with smell loss. And so it was then a trip I took to Dresden to attend a course I run by my colleague, Professor Thomas Hummel, where my eyes were open that actually there was more that we could do about this, there was more we could learn about this, there was more empathy we could provide to patients. And so it was really that set me along the lines of wanting to set up and provide a better service for these patients. And so at the beginning of, the end of 2010, I actually established the UK's first smell and taste clinic for patients with these disorders. And the following year, I was introduced to Duncan Boak, who together we founded the charity Fifth Sense, and continue that journey really to kind of hopefully provide a forum for support, but also to really kind of try and push forward an agenda for change in terms of people's understanding of smell and taste issues, and also providing better evidence through new research in this area.